I'm Dr. Sayed Alwedaie, and I'm a GP. I want to discuss a rare neurosurgical case which I had seen during my medical school, during my study in back in medical school 3 years ago. The title is Spontaneous Intracranial Hemorrhage, a sign of cavernous angioma diagnosis in pediatric age group. Basically, the case presentation is as follows. The patient was an 8-year-old Bahraini girl, not known for any medical illness. She presented to SMC, which is Salmania Medical Complex in Bahrain, with sudden onset of headache, and persistent vomiting. No history of trauma, no history of seizures. There was no significant past history. She was a schoolgirl. There was normal growth and development, and no significant family history of any other problems or brain disorders. Vitals, she was vitally stable, general appearance conscious, alert oriented. She was in severe pain. She was a skinny girl and she was not dehydrated. CNS examination was completely normal and insignificant. Other systemic examination non-significant except for mild abdominal tenderness. She underwent an urgent CT scan, both pre-contrast and post-contrast. In the pre-contrast CT scan, the left side, you can see, in the pre-contrast image, we can see the large, round, well-defined mixed high-density area in the left parieto-occipital region, suggestive of hemorrhage, surrounded by a rim of edema causing adjacent sulci effacement. That's basically in the left, the one that you see in the left image in this side. In the post-contrast image, which is, you see the image in the right side, you can see the normal meningeal and cerebral vessel enhancement. However, no obvious aneurysmal dilatation or feeding artery was noted at the site of hemorrhage. And the CT showed normal gray and white matter differentiation, no midline shift, patent basal cisterns, and unremarkable posterior fossa. So basically, the patient was admitted for close observation and monitoring. Analgesia was given, anticonvulsants was considered with GI prophylaxis, and also urgent MRI was ordered as well. At that point, no definitive diagnosis was made, whether it was vascular or a malignancy. So the patient was stabilized, and she was planned for digital subtraction angiography in 1 week. She was kept under close observation in the ward. However, on the day of a DSA, she developed severe headache and vomiting, and urgent CT scan was ordered at that moment. Urgent CT scan here in this image, you can see a rebleeding in the previous hemorrhage site with signs of resorption of the first intracranial hemorrhage. This is basically the interesting part of this case, because rebleeding and spontaneous hemorrhage doesn't occur for the case of cavernous malformations, but happened in our case. DSA was done next day. No vascular anomalies was seen. The patient was planned for surgical evacuation of the hematoma and exploration for any lesion. The patient underwent left parietal craniotomy and evacuation of the hematoma and lesion under general anesthesia with assistance of a neuronavigator. Intraoperatively, the appearance was consistent with venous cavernoma. It had Mulberry appearance, gliotic changes around it, and hematoma was completely evacuated. This is the intraoperative image of the case. You can see the lesions clearly. Can clearly see the image of the lesion here. This is the histopathological images, ABCD. This is the report, which in the diagnosis clearly mentions that there is left that this was left prior to occipital brain lesion excision. This is the sample, and the features are compatible with cavernoma with evidence of recurrent bleeding and focal calcification, no atypical changes seen. So basically, the patient was extubated post-operatively, kept in PICU for 2 days under close observation, and discharged to general ward. Stayed for 3 years and discharged home. She came in 1 week time to remove her clips. She was asymptomatic. She was conscious, alert, oriented, with 15 out of 15 GCS, no focal neurological deficits, and she was advised to continue on anticonvulsants for any possible epileptic seizures, and also for repeat of MRI.
Ой, подожди, погромче говори.
Also repeat for MRI in 6 months' time.
Так. Все получилось, все, что хотел? Щавель не забыл?
Cerebral cavernomas.
Ну, ты
I'm going to
сообщи,
discuss about the cerebral cavernomas in general.
Ну, сообщи, потому что, ну, понимаешь. А, уже даже сообщил.
One of the speakers, I
Ну,
think,
ладно, что ты там,
close the sound, close the audio, please. Can you mute your audio, please? Okay, the synonyms for cerebral cavernomas are cerebral cavernous malformations, cavernous hemangioma, or a cavernous angioma, cryptic vascular malformation, occult vascular malformation, or hemorrhoid of brain. Basically, these are developmental anomalies that affect the blood vessels. They can happen anywhere in the CNS. These are dilated sinusoidal channels, and they're lined with a single layer of endothelium, and there is no brain tissues. There's no brain or neuronal nervous parenchyma in between them. A prevalence is 0.5% in the population. 5 to 10% of all cerebrovascular malformations are supratentorial. 20 to 30% are familiar CCMs, and there is increased, the prevalence is high, relatively high in Mexican American families. About 30 to 50% of cases are asymptomatic. 20 to 30% of cavernomas may be associated with venous anomalies. Their bimodal presentation in the pediatric age can happen mostly happens between 3 to 11 years of age. In the adult age group, it happens between 20s to 40s, between 20 years to 40 years of age. Pathologically speaking, the lesion has a mulberry appearance. It has can be soft, either soft or hard. It can have either soft or hard consistency, and the size is 1 to 5 centimeters. There is enlarged capillaries with abnormal gap between endothelial cells, with thin collagenous wall and lack of smooth muscle or elastic fibers. Capillaries are immediately adjacent to each other, and there's no, as we said before, there's no intervening nervous tissue in between them. No feeding arteries or draining veins. And the interesting part, and there are some blood degradation products, hemosiderin staining with gliotic reactions can be seen in the adjacent brain tissues, which is significant, which is important for diagnosis pathologically. Approximately 50% of cases are asymptomatic, and the seizures can happen in 40 to 80% of cases. Females are more affected. Females are mostly affected. Affected more than males, more affected than females. I'm sorry. Sudden onset neurological deficits caused by hemorrhage can happen if the lesion is situated in the thalamic or brain stem. Risk factors for rebleed include prior hemorrhage, female sex, and pregnancy. The natural history, it depends on the location, and the presentation is usually with seizure. Subclinical hemorrhage seen in all cases, and clinical hemorrhage in about 12 cases, in 12% of cases. Annual hemorrhage rate is 0.5 to 1%, and the epileptic risk really depends on localization. It depends on where the lesion occurs. If the lesion is in temporal or frontal lobes, the risk of the epileptic risk seizure risk is 1.5 to 2.5%. The lesions may arrive de novo, may grow, shrink, and may remain unchanged. CT scan may show focal hyperdensity reflecting calcification or recent hemorrhage, and intravenous contrast may show faint enhancement. MRI is important, however, it is not as urgent as CT scan. DSA the same, it can demonstrate, it demonstrates no vascular anomalies. However, developmental venous anomalies may be associated with cavernoma and may be seen on angiography. Hemorrhagic metastasis, the differential diagnosis of this presentation can be a hemorrhagic metastasis due to melanoma, can be glioma, like oligodendroglioma, pleomorphic astrocytoma, xanthoastrocytoma. Could be hemorrhagic telangiectasia, can be due to multiple metastasis of a primary tumor anywhere else in the body. The management is can be medical, can be by stereotactic radiosurgery or gamma knife, or could be by surgical resection, which is the gold standard. Medical management is mostly focuses on control of the seizure. Basically, we want to prevent occurrence of seizure. So it is offered mostly to the asymptomatic incidentally detected lesions and surgically, and for those patients with surgically inaccessible lesions and unfit for surgery. As I said, it is mostly used for seizure control, and patients are refrained from strenuous activities, hard activities, and also they are advised not to take anticoagulants, and also they have to avoid pregnancy during medical treatment. Radiosurgery, mostly the principle of it is radiation injury to endothelial cell. The way it works is that radiation injury to endothelial cell causes release of growth factors and fibroblast proliferation. This causes a hyperplasia of smooth muscle cells and occlusion of lumen. And coagulation, necrosis of cavernoma, and obliteration of vessels were also a proposed mechanism. What is the indication of radiosurgery? Those with inaccessible lesions, like lesions in the thalamic area or in the brainstem, or deep-seated lesions. Lesions presented with minor hemorrhages, or also multiple lesions, and also it depends on patient's choice. So basically, those with inaccessible lesions or those lesions with minor hemorrhages are best treated by radiosurgery. Advantages of radiosurgery include reduction of rebleed rates, halting of growth of lesion, volume control, and seizure control. However, disadvantages include lower efficacy of treatment, and also radiation edema and transient or permanent deficits. Surgical management is the gold standard for treatment of cavernous malformations. The advantages include reduction of mass effect, no rebleeding from completely excised CCM, and the fact that the majority of patients become seizure-free after complete resection makes the surgical management the gold standard. And also intractable epilepsy may become well controlled, and complete cure can be assured. Disadvantages include patients with inaccessible or deeply seated lesions like thalamic or brainstem CCMs. After surgical treatment, they may develop some neurological deficits, and there is the morbidity and mortality is high in the surgical management as well. For surgical management, we need certain planning. We need MRI, a T1, T2 contrast, and contrast MRI with GRE or FLAIR sequences. Venous malformations should be looked for, and if lesion is in the eloquent area, then functional imaging along with cortical mapping should be done, and also neuronavigation protocol should be considered as well. Associated for surgical management, associated venous anomalies. Associated venous anomalies can be seen in 24% of cases of CCM, and these venous anomalies are the normal veins which drain the brain, and also in the surgical, when we want to manage the CCM surgically, we have to take into consideration these draining veins, because they might be the only veins supplying the brain. So every effort should be made to preserve them. So coagulation of these may result in venous infarcts and increase the morbidity of surgery, making the surgical management very risky. Surgical excision options are lesionectomy, could be lesionectomy or lesionectomy and excision of abnormal tissues, or lesionectomy and removal of abnormal area removed from the cavernoma. The outcome, with regard to the outcomes, when CCM are completely removed, risk of further growth and hemorrhage is essentially permanently eliminated. This is one of the major advantages of surgically treated CCMs. More than 80% of patients were same or better after the surgery, while few have worsened in various series. Cranial nerve deficits, motor deficits, meningitis, CCF leak are the usual complications of brainstem cavernous malformations. This is basically the summary of management. You can see it divided into symptomatic or asymptomatic. The symptomatic mostly treated by surgery or radiosurgery, the same for asymptomatic or the patients who present with new onset seizures. So in conclusion, cerebral cavernomas mostly present with seizure, headache, and focal deficits. Children rarely suffer severe life-threatening hemorrhages. Therefore, emergency neurosurgical intervention is very rare, which we have seen in our case. Surgery still remains gold standard for intracranial cavernoma. Conservative therapy is appropriate for cavernoma that are asymptomatic and for those who had one non-devastating episode of hemorrhage. Complications can occur and extensive informed consent should be obtained. Meticulous radiography and clinical follow-up necessary to monitor residual or recurrent disease. Presentation finished. If you have any questions, I'm ready to answer.